introduce Tracy officially because it's such an honor to have her here today. Tracy,
Mm.
on a personal note, is my teacher. She taught me all the functional medicine knowledge and helped me just through word of mouth build a huge successful practice in functional medicine, honestly, because of my skill set and how competent I feel about my skills in functional medicine. So having her on today is really
Mm.
a treat. And I want you to know that I'll give you a little background on Tracy. She's deeply passionate about transforming healthcare with the powerful combination of functional medicine and savvy clinical knowledge, or savvy clinical partnership, rather. She's a scientist who left the high-tech corporate world in 2007, and she built a wildly successful multimodality practice using functional medicine principles. And in 2011, she founded the School of Applied Functional Medicine. So Tracy's a scientist and engineer at heart. She has 3 degrees from MIT, further graduate education from Bridgeport University and IFM, the Institute for Functional Medicine. And Tracy, one of the gaps she found in some of her education years ago was just learning how to apply it and use the functional medicine in her practice. And she was so successful figuring out on her own that one of our colleagues said, "You should really teach this stuff." And she said it was like a light bulb moment. She started SAFM, and the rest is history. And the school is just fabulous. Honestly, I think it's like akin to a master's level in functional medicine. It's not a 5-day intensive course. This is like a real education, and I feel like so confident in my abilities to use functional medicine. And I'm so happy to have you here today because she's going to talk about gallbladder dysfunction, hepatic biliary dysfunction, and what to do about it. And there's so many missing pieces to this for so many practitioners. So Tracy, welcome, and thank you so much for coming on.
Awesome. Thank you, Jody, for that warm introduction. And indeed, I'm so excited for you, proud of you of the success that you have built, and not just the capability and confidence that you have, which I know feels wonderful, right? But the financial abundance, the business success you've built, helping thousands of clients with your practice. I think it's a wonderful testament to what's possible in doing this work, right?
Yeah, I can't
Anyone.
believe that my skill set, honestly, of what I'm capable of helping people with.
Yeah.
I never even dreamed I'd be able to help people not just get better, but really truly reverse their disease dynamics, which is just unbelievable. So, and
Yeah.
gallbladder is a big part of it for so many that and a lot of
It
practitioners miss this, don't they?
for sure, for sure. It is. And I'm going to go ahead and dive right in because, as usual, I've got a lot more to say than we have time to cover. So, um, as I mentioned earlier, I want to welcome everyone. And if you have particular questions that you already know, you want to raise about this question, this topic, please don't hesitate to put them in the chat thread. Mostly, I want to be of service to all of you today. I deeply appreciate that this community in Facebook here that Jody and her team have fostered over the past almost decade now is quite savvy and diverse in your specialty and how seasoned you are clinically. And I appreciate the pleasure and the privilege of teaching you today. The first thing I want to share is we're going to be talking about often overlooked functional drivers of hepatic biliary congestion. This is not going to be a back to basics. It's going to be a looking upstream with regard to what is often missed. And the slides are available to you. If you registered for this webinar, you'll receive them automatically. If you're watching the streaming, you can get the slides here at this link because I want you to be able to focus on the presentation, knowing you'll get the clinical tips and the references and whatnot for reference later on. But as Jody mentioned, I am on a personal crusade to save the gallbladders because we remove a lot of them collectively in healthcare each year. You might be surprised, over 800,000 gallbladder removals each year in the US the past couple of years. In many ways, we treat it as a optional body part. And this, of course, is a reflection of a woefully oversimplified and insufficient definition or belief around the role of this seemingly lowly tissue that plays a critical role in functional balance, not just in the GI tract, but downstream systemically. You could argue in all systems throughout the body. And in your practice, you are going to have many opportunities if you work with adults to both prevent gallbladder removal as well as to help people post cholecystectomy to resolve the root causes of their gallbladder disease and the need for the surgery, because taking out the victim tissue does not at all in any way, shape, or form address the upstream dysfunctions that caused the disease. And this is something that our students from all sorts of different modalities see over and over again. Because if we don't address the upstream functional imbalances that cause the gallbladder disease, they will, of course, strike again and cause other systemic dysfunction. The thicker bile, the sluggish, poor kinetics in the hepatic-biliary tree, the toxic burden, these mediators can be present not just a few months, but many years, perhaps decades, post cholecystectomy, not just driving that short-term syndrome type of GI dysfunction that we often see, but for many years later, especially driving downstream dysfunction in the gut. And I want to encourage you to think about gallbladder dysfunction of any kind as being a red flag for one or more systemic imbalances. It can be a powerful wake-up call, actually, with regard to one or more imbalances that you can become very proficient at finding, assessing, and fully resolving, as Jody alluded to. So my missive here is to inspire all of you with the opportunity to engage earlier and save the gallbladders in particular, because indeed this is not a rare procedure, but it is not without downstream dramatic consequences, not just immediately after surgery, but long-term downstream. Many practitioners think of the gallbladder and the bile as being some of the most boring aspects of our anatomy and physiology, right? It's just a sac with this alkaline sludge that flows into the GI tract and helps us absorb fats, right? Right? How complicated, how sexy, right? How high tech can it actually be? In general, we know the basics that bile is made in the liver and that there is a recipe involving water and bile salts and phospholipids and cholesterol and bilirubin that attain a particular lithogenic capacity. And indeed, we use the gallbladder really as a storage sac, if you will. And when we get a stimulus primarily from cholecystokinin to erupt the gallbladder and dump bile into the small intestines, it is downstream going to do much, much more than help to emulsify fats to support digestion and absorption. For our purposes today, it's critical to remember that bile is designed to be reabsorbed. Enterohepatic recycling in a healthy gut, especially with a healthy intestinal mucosa, is designed to absorb and put back into circulation via the ileum, in particular, about 90% of our bile acids. And this also means what happens in the gut doesn't stay in the gut, not just because of enhanced intestinal permeability, but because the bile will bring with it an awful lot of artifacts from the gut into the liver. And so it shouldn't surprise us that bile is a major mediator of metabolic function in the body. We do indeed use bile to emulsify fats, which allows lipases, fat digestive enzymes, to be more effective to support our need for essential fats and fat-soluble vitamins. And the pH of bile along with other substances like bicarbonate and stomach acid is a critical regulator of overall pH in the gut, which plays a huge role on the activity of enzymes in the gut and also what microbes thrive and which ones don't. But I want to expand the conversation here beyond these well understood and often marginalized functions, because the reality is that bile is an antimicrobial. And it is arguably one of the most important oversights of passive immune function in the gut for helping to maintain an appropriately balanced and diverse microbiome. And because we're helping to prevent dysbiosis, especially opportunistic overgrowth, bile helps to minimize excessive immune reactivity in the gut, excessive pro-inflammatory bias, and then the loss of barrier function that can result in the intestines. Bile is also, remember, a critical component of detoxification, primary escort or vehicle, if you will, for the end part of phase 2 and then phase 3 detoxification. It's how we get waste products from the point of conjugation, largely in the liver, through the biliary tree, down into the GI tract, and getting queued up for excretion in stool. And while bile plays so many critical functions, in an awful lot of our patients and clients, bile is also a very toxic laden substance. And so it shouldn't surprise us that it is a really different oxidative dynamic to be collecting bile in a bolus and erupting it into the intestines a few times a day in response to a meal, rather than the drip, 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 drip of bile that happens directly from the biliary tree into the duodenum once you remove the gallbladder. They are not the same. And we well understand now through research that the downstream impact on the gut can be quite markedly different when there is and isn't a gallbladder. Not such a lowly sack, as it turns out. We also need to be able to concentrate bile in a bolus form to help us to modulate inflammation in the gut, specifically as it relates to endotoxin or lipopolysaccharides in particular. We are with a good, healthy immune system and a good, diverse, plentiful microbiome. We are generating a lot of microbial debris on a regular basis. And there's a delicate balance of having that good, strong immune oversight, but also preventing a buildup of pro-inflammatory mediators like LPS that can eventually create mucosal damage on the lining of the intestines. And bile plays a critical role here in deactivating LPS. But let's take it even further, because bile salts don't just stay in the gut, right? We spoke of it earlier as obviously being largely reabsorbed. And indeed, bile salts also act as signaling molecules, both in the gut and outside of the gut. Plays a critical role in lipid synthesis and metabolism in the liver, in insulin signaling. And as a result, it shouldn't surprise us to learn that cholecystectomy can increase the risk of elevated triglycerides, exacerbation of fatty liver, and the progression of metabolic syndrome. Bile also helps to regulate oxalate absorption from the gut by minimizing the binding of minerals to maldigested fats. Research shows that gallstones and kidney stones can go hand in hand, and one increases the incidence of the other. So not a surprise that cholecystectomy may increase the risk of kidney stones, especially recurrence in individuals who have already wrestled with them. My point here is to expand on the importance of bile and the criticality of the role of the gallbladder in concentrating bile. Because of this system effect of bile and gallbladder concentration, even mild impairment in bile flow can have a marked impact on gut function and then downstream systemic effects. And as I mentioned earlier, cholecystectomy permanently removes the ability of the body to concentrate bile for a bolus concentrated delivery, but at the same time, limiting the gut's exposure to bile to just a few episodes each day, as opposed to a constant exposure to bile, but also in very low level concentration that can, this combination being able to increase the negative effects of bile by not giving the gut mucosa time to repair oxidative damage from bile, but also not getting the benefit of bolus concentration. So you want to be thinking about some of these downstream effects post cholecystectomy in the people you're supporting.
And we're seeing it, I think, in younger and younger patients in the population too. I know my daughter's friend at age 19 had a cholecystectomy. 10 years later, she gets diagnosed with celiac. And I think it's really interesting what you're saying about the gut lining, all the assaults to it without a gallbladder. And now I can just see, obviously she's genetically predisposed, but how that unfolded.
Absolutely. Absolutely. And I think in more and more people in youth and adolescents and in teens, we're seeing early stages of metabolic disease
Mhm.
and the fatty liver that can be a common upstream driver in this biliary congestion, right? And of course, what we're referring to here is poor kinetics, right? Poor bile kinetics, where there is either poor motility and or poorly flowing bile. This can be because of supersaturation, whether that is from too much cholesterol being concentrated into the bile. We're going to talk in a moment about why that often happens, or too little water, which can be also just an artifact even of the low grade dehydration that a lot of people wrestle with today. We can have inadequate phospholipids or bile acids. And then again, some type of underlying motility issue, which can have a number of root causes as well. And when we have this sludge, if you will, keeping in mind that bile is very toxic, right? It is carrying a lot of waste products, endogenous waste products, as well as exogenous toxin metabolites through the liver and through the GI tract. So this can indeed lead to the development of what we affectionately call sludge. And this can progress to stones that eventually may lead to biliary obstruction, then gallbladder disease, and then the acute, indeed, potentially life-threatening scenarios that might necessitate a cholecystectomy. So we want to understand that the effects here are not only multi-symptom, but also multi-system. We often focus on dynamics like inadequate vitamin D or inadequate vitamin A, despite supplementation, for example, perhaps being an artifact of challenges in the hepatic biliary tree, or issues with regard to toxin clearance. But we want to start thinking about this being a downstream victim, if you will, of upstream dynamics. And like any other scenario, right, where you take care of the victim, well, that's appropriate and responsible. But if we don't actually get at the culprit, we should logically, scientifically expect there to be more dysfunction. So the savvy practitioner, as I know you all are, must always be asking, who is this person? And certainly we need to take care of the victim tissue, right? We can rescue the gallbladder, we can rescue the biliary tree. But if we don't go further upstream and assess what are the unique mediators of this congestion in this person, then we're missing a huge opportunity to do our best work clinically. So let's dive in and talk about some of the most common mediators here, especially for women, but I would argue for men as well, especially obese men, but especially for women. I want to encourage you to begin thinking about estrogenic overload as being a major mediator of hepatic-biliary congestion. Maybe one of the best examples of thinking about these two systems as being separate, but high estrogenic states will increase the concentration of cholesterol in bile and decrease the bile acid output into bile. This is going to change the recipe of bile, if you will, making it much more likely to be sluggish in kinetics and to promote this biliary sludge and stone formation. So, for your women clients in particular who have highly symptomatic PMS, long, heavy menstrual bleeding, maybe passing clots, perhaps they have a history of endometriosis, a history of hormonal migraines, but we want to be asking and questioning how might that high estrogenic state be affecting the health of this anatomy, both in terms of how it affects the gut itself, but also in terms of how it affects metabolic function. And you're likely well familiar with some of the most common contributors to estrogenic overload. But as we know, it is seldom about ovaries gone wild, right? Instead, it is about other mediators increasing the estrogenic signaling in the body. Part of that has to do with perhaps low progesterone in order to mediate estrogen receptor function. But an often overlooked component of this has to do with endocrine disrupting chemicals and how completely separate from endogenous estrogens, these now ubiquitous chemicals and daily habit use can be stimulating estrogenic signaling completely separate from human endogenous estrogen. Or in the case of endogenous human estrogens, where might poor estrogen biotransformation and clearance actually be at play? And throughout today's presentation, I'll be using blue text in order to highlight what I feel are some of the most important and indeed often overlooked components. But it is critical to assess this dynamic. It might surprise you that estrogen dominance may increase the risk of gallstones or gallbladder disease by 2 or 3x. And so it's essential that we assess this and address the roots that we find. For a lot of practitioners, I find that we often don't do a deep enough dive into endocrine disrupting chemicals in order to help patients to make step-by-step change. Often we talk about reducing toxicity and reducing chemicals, but your average American human has no idea what you're talking about when you say that. A lot of people think their lifestyles are very non-toxic. And until we do a deep dive, an inventory with them, not a checklist we give them, but encouraging them to do things like line up all their personal hygiene products and take a picture and send it to you, line up all their makeup, line up all of their household cleaning products, all their laundry products, an awful lot of the devil in the detail here has to do with things that people use on a daily basis and take for granted. And I think a key part of making detoxification or toxin avoidance accessible to your typical patient is giving them a place to start, right? We have to help people to be successful with the first couple of steps in order for them to have inspiration to continue the journey, right? Most people, if you say, here's 50 things you should avoid or 30 things you should avoid, it's just overwhelming. People are much more likely to do nothing because the task feels too big. But if we can do an inventory with them and identify detoxifying challenges, if you will, or opportunities, we can recommend, for example, I believe the number one should be Do not use any air fresheners in your home, right? All of those little phthalate soaked cardboard trees that we hang from the rearview mirror in our car, all of those smelly plug-in air fresheners. It's hilarious to me, and just exquisite marketing that they get away with calling these air fresheners. There's nothing fresh about it. It smells like a chemical vat. It just has a fake fresh scent that a lot of people are brainwashed into thinking is freshness. And until you teach them that that is loaded with phthalates, that then the heat reflecting off the dashboard and in their car when the car is closed up is putting more of those phthalates into the air. So when you open the door, get in the car and breathe in the estrogenic capacity, if you don't teach them that, they don't know.
Don't get
Anything
me
that is,
started on
oh my gosh,
laundry
yes,
sheets, dryer sheets, laundry detergent. It's like
dryer sheets,
oh,
fabric softener. These are other great examples. Let's talk about dryer sheets. This is the stupidest thing ever. You take a piece of basically plastic resin, it's really a polymer type of substance. You soak it with phthalates, this fake fresh scent, and then you put it in the heat of a dryer, which will free up plastic compounds in the dryer sheet to make the fragrance stick to your clothing so that even if you wear it for days and days and days and days, the chemicals are still sticking to the clothing, except for when you sweat. And the moisture and the warmth of your body will cause you to absorb these chemicals, which has been well demonstrated. You have to wash an article of clothing that's been in a dryer with a dryer sheet, in my experience, in my home, about 10 times
hmm.
to get all of that chemical off of that item of clothing. This is a dramatic toxicity exposure opportunity. And I'm just talking about one thing, right? But we can tell stories, we can use simple analogies and examples to get people inspired about the opportunities at hand and to attempt one at a time, right? So they can get a win, they can celebrate, because that will inspire their willingness, their enthusiasm for doing more things. We have to make avoiding these substances doable, or it is one of the areas of the clinical partnership that most often falls flat because it's simply overwhelming. We are living basically in a chemical vat and a chemical soup. And so, step by step is critical for keeping your patients from just getting overwhelmed and disengaged. But you want to think about estrogenic activation and where might this be a major mediator of hepatic biliary congestion and dysfunction, and endocrine disrupting chemicals as being an often overlooked, I believe, likely major mediator of this. Next, we want to talk about metabolic dysfunction. Now, I'm fully aware that you all know that type 2 diabetes is a natural progression of insulin resistance. But what we often aren't doing in the vein of metabolic disease is investigating and intervening early enough. We often are waiting for this diagnosis of at least pre-diabetes before we take action. And I think this is a travesty because we missed the first 10 to 15 years of metabolic dysfunction where we could be having an impact during those early stages, especially stage 2 or hyperinsulinemia. It is, as you know, the elevated levels of insulin that can drive increased fatty incorporation into our tissues, not just the lean muscles of the body, beginning with the large muscles in the leg, but also in the liver. And a congested liver is going to be much more likely to have dysfunctional bile synthesis. Again, with that higher cholesterol ratio and the lower bile acid incorporation into bile. And so this is something I encourage you to look for early on, way in advance of blood sugar getting elevated at all, in terms of helping people to avoid metabolic disease. I'll show you some more information about that in just a second. But this is an opportunity to be looking at either fasting C-peptide or fasting insulin and looking for even subclinical elevations. This is one of the best examples of the fact that the optimal zone of lab values is frequently very different from the normal range. And indeed, more than the entire upper half of most fasting insulin or fasting C-peptide ranges are evidence of metabolic dysfunction. We don't want to miss the opportunity to engage much earlier. Ideally, when lifestyle change with simply lower glycemic diets, maybe even lower carbohydrate diets, if there's a disconnect between a person's activity level and their carbohydrate intake, weighted exercise, extended overnight fasting, not too much too fast, beginning only at 12 hours and increasing slowly to make sure people tolerate it well. But if we're thinking that we want to wait until the CGM data is concerning before we engage in metabolic dysfunction, then we may be missing the first decade or more of that disease dynamic. And so we want to intervene early to address this because hyperinsulinemia drives fatty liver, drives downstream bile and gallbladder dysfunction. Now, similarly, an over-challenged liver may indeed also struggle to have optimal bile synthesis with the right ratios of ingredients. And there's an interesting kind of vicious cycle here where a high toxic load can lead to a thicker sludge-like bile. And if we have poor gallbladder emptying, we can end up with more challenges for dysbiosis in the intestines because, as I said, bile is an antimicrobial agent. But then the dysbiosis, the opportunistic overgrowths of microbes can change bile acid deconjugation and recycling. And so this goes back and ends up affecting the liver. And we can end up with more toxic reabsorption back to the liver, further amplifying this toxic load on the liver. And this is where not only endocrine disrupting chemicals, but the myriad different toxic substances that our typical patients are bringing into their bodies every day via the nose, via the mouth, via the skin, the things we slather all over our body. This can lead to toxic overload that is affecting bile kinetics and bile concentration. And then that imbalance can further challenge the liver. So we want to be looking for toxic exposure and then classic symptoms of toxic overload. We want to be looking for potentially toxin panels, right? Lots of good functional panels can be looking at levels of different toxins. And then some of the classic symptoms of liver overload, especially GGT, gamma glutamylase transferase, which is a marker of glutathione recycling, especially in the liver, which lets you know that the liver tissue is needing to generate more and more antioxidant function in order to serve itself. It's an important wake-up call. But I want to speak for a minute to this notion of metabolic disease beginning in the gut. And I'm going to give you an opportunity in a little while to learn all about all these other dynamics because you can learn to master and become not just super knowledgeable about, but very capable of working with all of these different dynamics in the gut because bile acids are just one component of gut function that affect metabolic disease. And I don't have time to go through this entire slide. This is just a sample slide from our gut course. But when we understand the number of ways in which gut imbalance can affect metabolic imbalance, we understand why it's critical to take care of basic gut functioning. GLP-1, for example, is so popular, so well understood now as an incretin, right? That is not only highly affected by and regulating gastric emptying, but it's also regulating first phase insulin release. This is insulin regulation in the gut. Further downstream in the brush border of our intestines, we make a family of enzymes, the DPP-4 family of enzymes, which help to degrade those incretins so that we put out plenty of insulin, but not too much. But then it goes even further than that. Bile acids, normally released in a bolus from the gallbladder, are important episodic bolus signaling molecules that trigger insulin release via the farnesoid X receptor family. And we know that a bile acid metabolism is altered in type 2 diabetes. This makes perfect sense when you consider how bile acids themselves affect pancreatic and liver metabolism. Their dysbiosis, right? And the lipopolysaccharide load that we experience in the gut, and the loss of barrier function, and the possible higher levels of circulating lipopolysaccharide. These all play a critical role also on insulin signaling. So these are all functions that I've been described in the beginning as balances that bile contributes to. And when we permanently change the dynamics of bile by removing the gallbladder, we are creating permanent imbalances that a person then has to try to overcome with regard to predisposition for disease. I don't have time to go through this now, but I did want to share it with you because, as I mentioned earlier, we often see that practitioners are waiting for stage 3 dysfunction where blood sugar is elevated, hemoglobin A1C is elevated, right? A CGM shows more frequent surges or longer post-meal elevations before we engage and do anything about what is at play. I would argue that the most common longer phase of metabolic dysfunction is actually phase 2, which is a long stage of progressively increasing fasting insulin, where blood sugar is optimal, or it might even be a bit on the lower side. We always want to be questioning when someone's diet and lifestyle against an optimal hemoglobin A1C doesn't make sense. Don't ever celebrate it just because it looks good. We always want to be asking, who is this person? Did these lab results make sense in the context of who is this person? Someone eating a standard American diet and having a very sedentary lifestyle with a hemoglobin A1C of 5.0 does not make sense. And very likely subclinical fasting insulin is happening behind the scenes. This can be increasing the likelihood of downstream hepatic-biliary disease. So we want to intervene earlier, ideally even up in stage 1, or even looking at pre-disease disposing factors, especially lifestyle changes and genetics. All right, what else is often missed, even amongst our community? Subclinical intracellular hypothyroidism. We all know that it is way more common, certainly than is believed in conventional medicine, where we're waiting way too long in order to assess it. We're often using the wrong lab markers to wait to diagnose it. But it's important to understand that even subclinical hypothyroidism can be impairing GI motility, impairing hepatic clearance, impairing bile salt synthesis, and even overt hypothyroidism may increase the risk of gallstones by 2 to 3x. Our huge missed opportunity is to look for this when it's subclinical, even when TSH is seemingly optimal, and to understand that what we're measuring in blood thyroid hormones is at best a reflection of what is happening intracellularly. We do a very deep dive at SAFM on thyroid function because many practitioners forget some of the more subtle thyroid hormone physiology, and that the vast majority of thyroid hormone conversion is intracellular and therefore not measurable. And especially with D2 deiodinases, cells are creating their own localized supply of T3 thyroid hormone. And different tissues can have different thyroid hormone metabolism at different times, depending on those tissues' needs and challenges. So, yes, we want to look at labs, but we also want to honor the qualitative side of presentation. There are many, many, many women out there, even seeing functional practitioners complaining of constipation, dysmotility, bloating, and distension, cold intolerance without anemia, dry skin, fatigue, can't lose weight no matter how hard she tries, that are being marginalized simply because their TSH looks optimal and even their serum T4 and T3 look seemingly optimal. We need to go beyond that in terms of understanding that intracellular hypothyroidism can still exist, even when lab markers are seemingly optimal. And this is an imbalance that you can really learn to master early on, but we need to be looking for it and supporting, in particular, the nutrient insufficiency that might be at play in poor intracellular conversion. I was reading last year when we were doing a separate bonus course about this, the fact that we're increasingly starting to see that local hepatic hypothyroidism might often be one of the original mediators of fatty liver, and that a subclinical hypothyroidism might be the very first thing that starts to get that fatty incorporation that then causes problems with bile, that then causes problem with glucose regulation. And it's this forward feeding dysfunction. And so we want to be looking for where this presents itself, not just quantitatively, but qualitatively. We also want to think about neural dysfunction, that the gallbladder, like anything else, has to be stimulated into action. And we need good parasympathetic vagal transmission, specifically via acetylcholine, to drive all GI motility, including that of the hepatic-biliary tree, and also digestive secretions. Things like cholecystokinin release are not just affected by the amount of fat in our meal, for example, but it also has to be stimulated from a neural viewpoint. And this is where anything that interferes with normal um, neural transmission can end up causing hepatic biliary challenges, especially if there's other evidence of any other type of neuropathy, right? Peripheral neuropathy may be very easy to spot based on symptoms. But if we're experiencing neuropathy in one area of our nervous systems, it should be our logical conclusion that it's going to be present elsewhere. And especially given how stressed many of our patients are, and how this can create more of a sympathetic dominant nervous system mode that is naturally going to suppress vagal transmission and affect all digestive motility and secretions. We shouldn't be surprised that whether it's about stress as a mediator or nutrients as a mediator or inflammation in the nervous system like from high viral load, that all of these could potentially have an impact on poor gallbladder emptying that can lead to congestion and the seeding of stones in this tissue. And this is where we need to work on greater emulsification. This is where agents such as um, taurine and phosphatidyl choline, phosphatidylserine can be really quite helpful for addressing some of that sludge, if you will. But we have to reestablish this optimal neurotransmission and assessing what is a unique individual doing on a regular basis to create big chunks of parasympathetic activation in their lifestyle. And this is part of the savvy clinical partnership that Jody alluded to earlier. It's something I'm crazy passionate about because no amount of scientific knowledge on its own is going to help anybody get well or stay well. Because if you can't create a strong, trusting relationship with each unique patient and then educate, inspire, and empower them to make different choices, then our scientific knowledge, my friends, is really not worth very much. I mean, it's interesting, right? The geek in me sees the geek in you, but it's not going to help anyone. So we believe at SAFM, it is just as important that you become truly expert at forming that clinical partnership and running that clinical leadership. That is just as important as the actual science itself, because the science on its own doesn't inspire and empower people to do anything. In fact, it often just overwhelms the patient and makes it less likely that they're going to keep working with you. So we have to be able to teach them what is at play and inspire them to make change. I do want to say a word about GLP-1 agonists because increasingly we are learning that these medications, naturally, not surprisingly, as part of their normal functioning, are creating poor gallbladder emptying and therefore increasing the risk of gallstones. This is both dose dependent as well as duration of use dependent and is a really key consideration as more and more of people using these drugs are coming to your practice. In our normal body, incretins are regulating gastric emptying, and then changes in gastric emptying are regulating incretins. And so there's a balance. But in its medication form, the GLP-1 agonist is engineered in order to resist degradation in an unnatural way and therefore promote sustained effects that are not counter-regulatory. And if you slow motility in the upper GI tract, of course, logically, you're slowing it in the hepatic-biliary tree as well. And this is especially concerning given individuals using these meds are much more likely to be morbidly obese and already have fatty liver, already have biliary tree dysfunction in the first place. And so this is a critical element of education, inspiration, and empowerment, whether you are the prescriber or not. I think it also speaks to the wisdom where this medication is merited and maybe very appropriately prescribed, making sure that we are using low enough doses that are minimizing some of these other undesired consequences, but also requiring lifestyle change on the part of the patient. So it's a participatory partnership of effect, not just from the magic pill of the drug, but through the combination of the medication support paired with the essential role of progressive lifestyle change, especially around diet and movement.
So glad you brought that up because there's so much people say injury with this medication, but I really think a lot of it has to do with what you talked about and when they're losing weight so rapidly, freeing up toxins, which further aggravate the gallbladders in ways that you mentioned earlier. So I think it's just a double whammy.
Absolutely. And that's another great point as well. Rapid weight loss, right? Very rapid weight loss is often a toxic nightmare because of the role of adipose tissue as basically depot storage for toxins. And when people are rapidly losing weight, it is putting a tremendous amount of toxins back into circulation, which can easily overload our detox pathways. I think especially our phase 2 pathways, and lead to a pro-inflammatory bias that can promote disease in and of itself. It's very important to make sure that a body is prepared for a toxic surge as a result of weight loss. I'm really glad you brought that up. So, lastly here, when someone has lost their gallbladder and lost this ability to engage, right? We want to be expecting this upstream dysfunction, right? The upstream mediators that I just spoke of, as well as the more immediate dysfunction in the gallbladder itself. And I'm giving you here on this page a number of clinical tools that you can use to engage overtly and be able to work on resolution of sludge and even resolution of gallstones. I've supported a few clients to do this who were even able to avoid surgery even after they had had gallbladder attacks. And so it is absolutely doable, especially earlier on, right? Obviously, the sooner we engage, the less there is to resolve. But we can be looking for some of this dysfunction in particular, for example, with subclinically elevated alkaline phosphatase. You'll often see it 90, 95, 101, right? Which is still in the normal range and often ignored, but as being evidence of excessive alkaline phosphatase spillage from the biliary tree because there is a backup due to congestion and potentially poor gallbladder emptying. You might also see elevated levels of conjugated bilirubin for the same reason, right? If bilirubin itself is elevated at all, you can do the breakdown between conjugated and unconjugated in order to see which is more elevated to help you address the root cause. But the combination of agents such as choline and inositol or taurine and D-limonene can be extremely powerful for being able to step by step resolve the sludge in the biliary tree. If there are known overt stones, then UDCA or TUDCA would be prudent to add to that as well. But if there are truly existing stones or a prior incidence of gallstones, we want to keep in mind that anything we do that improves kinetics of the gallbladder itself might actually be dangerous. And this is where order of operations is everything in the efficacy and sometimes the safety of functional intervention. We don't want to take a gallbladder that's struggling with stones and start rapidly increasing its emptying. Whether that is through the use of things like digestive bitters or high dose extra virgin olive oil or artichoke, or even things such as increasing thyroid hormone doses. Instead, we want to work on improving emulsification and resolving stones first before we think about low and slow improving the kinetics. And this is why sometimes individuals can be working on this type of challenge, but they're working with an inappropriate order of operations. It's really critical to learn in what order do you peel away the layers of the onion. Just diving in and trying to peel them all at the same time doesn't work very well at all. And not only can it be dangerous, but it also might result in the patient who's doing a lot of things, but not really getting better because we're trying to address too many imbalances at once. And you can learn to be very confident and capable at picking of order of operations. This is where complex case practice is so key. But my primary message for today is to inspire you to remember that gallbladders are worth saving to the best of our ability. And that even if you are engaging with patients and through the functional medicine lens, you're definitely going to get them, because patients who've already had a cholecystectomy, it's 2 years, 5 years, 10 years later, they're still struggling from the imbalances that caused that gallbladder disease. And those imbalances are now causing other symptoms and suffering. So I want to inspire you to engage in order to actually promote the regression of these upstream dynamics.
That was amazing, Tracy. Thank you so much. I want to tell you all, like, listening to Tracy, I know this was so much information at once, but in the school, you get to listen to the classes. She recommends 3 times, which I recommend you take the recording of this and listen to it again, because you'll get more out of it the more you listen to it. But the other piece of it is the repetition through case studies, like Tracy mentioned, and that you can have all the knowledge in the world. If you're not using it in your practice, it's not going to be helpful. So in the school, you're going to get to have hundreds of case studies throughout your course of the schoolwork, and you get to actually participate and ask questions and get answers and see what Tracy would do in this case when the student, a fellow student, will present a case. So it just helps you reinforce the knowledge and see it working in a practical case, not just, so you're doing it hands-on. And that's why I feel so confident and competent when someone comes to me with any kind of health issue. I feel like I know I can help them, even if I've never addressed that disease before, because we understand all the upstream dynamics of disease. So it's just such a rich knowledge. And I hope you all got a lot out of it. Tracy is actually offering something very special to our group today. Tracy, do you want to talk about that?
I do, for sure, because first of all, thank you. Thank you, Jody, for giving me the opportunity to be able to share this knowledge. I really appreciate that. But if this training, even the small sample that I've shared today, is inspiring to you, um, it's really essential that every functional practitioner have significant clarity and confidence about the entire gut. If you're going to master one system through the functional medicine lens, this needs to be it. And we have at SAFM a standalone clinical course that gives you 8 weeks of access to a deep dive. And for those of you who might still need CME for this year, this is a fully self-paced course that's worth 10 CME, that does a deep dive into the entire gut, not just related to gut function and gut challenges, whether it's IBS or diverticulosis or pancreatic insufficiency or gallbladder disease or hypochlorhydria and H. pylori and candida and all those things, but also how do gut imbalances affect the systemic body. This hones in on some of our very, very best, not only scientific, but also clinical content. And I want to make this available for participants here
Wow.
for a limited time. This is a 10 CME course for $497. We're going to leave that open until the 19th of this month, which is a $200 savings. And it's a powerful opportunity to take your learning to the next level. I want to share that we have a lot of people, actually over 1,000 practitioners have taken this course over the past several years. And we receive just wonderful affirming feedback, not only from people who are newer to functional medicine, but even seasoned functional practitioners who loved all the clinical pearls and missteps and considerations that they picked up in the course. As Jody just well said, and I thank you for those kind words, I am so passionate about real life complex case practice, because there are too many practitioners out there that have reams of scientific knowledge, but they don't have deep clinical capability. And those are two very different things. And so all of the nuances to help us to apply the science to unique individuals is something we're really passionate about at SAFM. So yes, I'm excited. The link is here for folks to access this. And I would be delighted to give you this deep dive and your own time and your own pace over the next couple of months in order to take your knowledge to the next level.
And even if you feel like you have mastered the gut, you should definitely take this course anyway, because, I'm sure you learned a few clinical tips along the way about the gallbladder, even though you probably know a lot about the gallbladder, just all the interconnectedness. So taking this course also is the level one gut course in the school. And so you're getting a taste of what the broader education is as well.
Mhm.
And it's just an excellent course and the best CMEs you'll ever take. It's so interesting and amazing. You'll learn so much in it. So I definitely recommend it. But you'll just get a really deep, rich knowledge of functional medicine and confidence and competence. Abby is in the chat today, Dr. Abby Siegel. She's an MD. She highly recommends SAFM. She's a pediatrician and has been a long time SAFMer as well. Lisa Lamana says she also highly recommends SAFM. Life and knowledge changing, perfect complement to my psychotherapy practice. Thank you guys. That was unsolicited endorsements here. We appreciate it. And so anyway, thank you. You're getting a lot of love on the chat thread, Tracy. It's been just amazing. So appreciate it and hope to have you back again in the group. Go ahead.
Yeah, I really appreciate it. It's a powerful opportunity, right? In order to bring some pearls and some insights to a rich community. And I want to end by just thanking you, Jody, for all the work that you've put in for literally almost a decade now, right? In creating a platform where practitioners can engage and connect. And so I want to thank you for your leadership and the way you've kept showing up over all of the craziness of the pandemic and all of the ups and downs culturally that we've experienced to give people a platform for connecting and gaining more knowledge and making more connections. I really appreciate that.
Tracy.
Thank you. And thanks everyone on the line for joining us today, for making time. I know you're all very busy and I appreciate the opportunity.
All right. Well, take care, everybody. If anyone has any questions, you can put it in the chat. And is there anything you needed to know? I know there were some questions on the relation of the thyroid. I think you covered that pretty extensively, which is great with the with the gallbladder. Um, yep. Saying always learning something new, listening to Tracy. All right. I think we'll end on that. Take care, everybody. Have a great day. Bye-bye.
Thank you.